Hello, my name is Regina Petricus, and I'm a acute care nurse practitioner in our emergency department. I am currently a DNP student at Brandman University, and I'm excited to present my clinical scholarly project to you today. The focus of my project is to order an appropriate head CT in practitioners in triage for patients who present with closed head injuries. Specifically, the question to be answered is, in adult patients who present to triage in the emergency department with closed head injuries, does the use of nurse practitioner standardized protocols as compared to seeking attended approval or timely ordering of head CTs imaging is observed over a 3-month period? Head CT imaging is the most commonly ordered test to assess patients for closed head injury, accounting for more than 1 million head CTs per year. Not every closed head injury patient requires a head CT, as there is a high cost associated with this test, which includes money, resources, time, overcrowded in emergency and radiology departments, confers little or no benefit, and incidental findings of no clinical significance, and involves radiation to the patient. On the other hand, one must not miss intracranial injuries, as the consequences of error are great, and any delayed treatment will affect morbidity and mortality. 50% of this population will have an acute finding, with less than 1% requiring neurosurgical intervention. A delay in diagnosis is a form of diagnostic error, which is defined as a non-optimal interval of time between onset of symptoms, identification, and initiation of treatment. Delayed diagnosis occurs when the correct diagnosis is delayed due to failure or untimely ordering of tests. Ordering of head CTs in the emergency department was done independently in triage by the nurse practitioner based on standardized protocols. In July of 2017, standardized protocols were changed and attended approval was required to order head CTs. Head CT screening by nurse practitioners dropped by 58.1%, which correlates with the change in protocols in quarter 3 of 2017, which is July, August, and September. The theory is that the number of immediate CTs did not change, but rather the timing of the order placed did, that the definitive provider, instead of the screening nurse practitioner, is now ordering the CT. This has the potential for delay in diagnosis, which can affect patient treatment, morbidity, mortality, and delay in movement of patients in the emergency department. On the other hand, it is estimated that millions of dollars could be saved every year by not doing unnecessary head CTs. Unnecessary overuse is defined as the provision of medical services with no benefit or for which harm outweighs. Therefore, a balanced approach is required to ensure ordering necessary head CTs while considering the potential downside of over-imaging. There are more than 2.5 million closed head injuries related visits to the emergency department annually. In the United States alone, injuries account for 1 to 2% of emergency department visits. In our emergency department, this would equate to 1,630 visits per year. Given the number of patients this project involves, stakeholders will need to play a significant role in the implementation and continuation of this project. Stakeholders will include administrators, the chair department, the VP of operations, the RME director, the ED director, and practitioners' attendants will also need to buy into this project. Administrative support is essential for approval and financing of the project. Administrators have the ability to change the standardized protocols to include the validated decision-making rules for determining which patients are at very low risk of clinical importance brain injury, and therefore CT imaging can be avoided, as well as defining those patients who need emergent imaging. These decision rules allow for risk stratification of patients based on clinical findings. They are based on research that has been used to generate evidence-based guidelines to assist in decision-making. They are very good in identifying which patients require neurosurgical intervention. Yet despite these decision rules, ED providers obtain non-indicated CTs in 23.1% of patients in the United States. What is even more surprising is that 80% of emergency physicians were aware of one of the decision rules, and only 12% were using it clinically. This is an opportune time for education to improve the use of decision rules in our department. The nurse practitioners will need to be taught how to use the decision rules, and therefore the standardized protocols, which will allow the nurse practitioner to use their skills independently, consistent with their knowledge and training. Attendants will need to support and allow for the nurse practitioner to practice independently while still being available for consultation. The first step in educating the shareholders is by providing information regarding the frequency of head CTs being performed and differentiating between those that are needed and those that should be avoided based on validated decision. One can demonstrate that the appropriateness of ordering head CTs can be independently done as long as the decision rules are followed. Learning involves imitation, reinforcement, and insight, which all can be accomplished by incorporating the standardized protocols into practice. The conceptual framework to be used in this project is the Roy adaptation model. This model presents the person as a whole adaptive system in constant interaction with internal and external environment. The main task of the human system is to maintain integrity in the face of environmental stimuli, while the goal is to foster successful adaptation. The stakeholders, administration and attendants, are comfortable with adding attendant approval to the ordering of head CTs. While the nurse practitioners believe that the environment should support them in making decisions based on their training, education, expertise, and licensure, and therefore should allow them to practice as independent practitioners. To educate the stakeholders involved, one must show that there is a delay in ordering head CTs. This will provide new environmental information which should lead to change in the policy as well as a change in behavior resulting in successful adaptation to the new model of care by all shareholders involved. Behavior is viewed as an output of the human system and takes the form of either adaptive responses or ineffective responses. These responses serve as feedback to the system, with the human system using this information to decide whether to increase or decrease its effects to cope with the stimuli. Monthly QI monitoring will be initiated to maintain this feedback and evaluate the appropriateness of ordering head CTs. As already stated, our department will see 1,630 closed head injuries per year. Estimate that 15 minutes is required for consultation per patient with the intent of ordering the CT on the appropriate patient. 15 minutes by the nurse practitioner and an additional 15 minutes by the attendant equates to 15 hours a year that could be used on other patients, which could decrease door-to-door provider time, as well as length of stay and ED wait time. Financially, one can save potentially $24,450 used in nurse practitioner for attendant consult time and an additional $71,720 used for physician consultant time with the nurse practitioners. Indirect benefits could be $5 and recruitment costs, as the nurse practitioners have voiced concern of losing independence practice based on their knowledge, training, and skills, which has led to dissatisfaction and turnover. The costs are minimal to implement the standardized protocol as they are already in place. Estimated total of 2 hours to change the protocol at $120 and monitoring QI at 2 hours per month for a total of $1,440 per year. There's a one-time learning session for each nurse practitioner for a total of $960. As one can see, the benefits far outweigh the cost in this project. This information regarding the use of validated decision rules and determine which closed head injury patients require an immediate head CT can be placed in the nurse practitioner's standardized protocols. They have been shown to be effective and cost savings by deterring unnecessary head CTs. Allowing practitioners to practice independently also has a cost savings as compared to the money and time spent for attendant approval. Stakeholders will be kept informed of the project by monthly QI reports. Administration can facilitate this project by allowing access to the list of CTs and patients' records. Once the results are evaluated, the stakeholders can support the initiation of decision rules into the standardized protocols, which will assist independent practice and improve patient care and outcomes by decreasing the time to head CT ordering in this specific population. To evaluate and answer this PICO question, information will be obtained by this DMP student at no cost to the department. I will obtain a list of all head CTs done in the department in 3 months prior to July 2017 and all CTs done quarter 3 of the same year. Charts will be reviewed and traced back to the patient's initial presentation. If they came through triage and complained of closed-head injuries, then the time of the nurse practitioner screening will be noted, as well as the time the head CT was ordered. Time from screening to ordering will be compared in the first group, independent practice with standardized protocols, to the second group, attendant approval. This will be analyzed and determine if there's a statistical difference in the two different practices. If the first group, independent practice with standardized protocols, shows a savings to order head CTs, then administration will be approached to change current practice in this emergency department. In conclusion, our emergency department has seen an estimated 1,630 closed-head injury patients this year. Head CT is the most common test used to assess this population. The majority of these patients do not need a head CT based on decision rules which allow for risk stratification. There is a subset which do. In these patients that an immediate head CT be ordered without any delay in an evaluation. Currently, the practice of obtaining attendant approval prior to the ordering of the head CTs. This is costly in terms of money, resources, and time. This project will ask if the use of nurse practitioner standardized protocols as compared to seeking attendant approval leads to more timely ordering of head CT imaging. Stakeholders need to be educated and involved in this project for it to be successful and meaningful. I thank you for your time.